very important for you have these concepts. Now, another thing is intermodality difference. Be imaginative. So if I show you a choledochal cyst on a, let's say an MRCP, you will immediately pick it up unless you stretch your imagination. So these kinds of things I'll show you in examples. Now, contrast studies as in bariums, they are important for the exam. Now, why I say important is that your chances of getting a contrast study, I'm not saying all of you will get a contrast study, but you might get a contrast study. So I know that the current generation, you people are, you don't have experience. Wherever I go in the world, I ask everybody, and I think contrast studies for obvious reasons have gone down. So it's a weak link for you. And the examiners know it. So still contrast studies are asked in the exam, and I am going to show you a lot of contrast studies intentionally. You are very good in CT, but you are not good in contrast, so I will concentrate there. And so this is one point where we will, I'll show you many cases. Many cases which I'll show you, particularly on contrast, is just for pattern recognition, Aunt Minnie type of cases. Once you see them, that's it. But if you don't see them, then, you will struggle. So I will show you many cases for pattern recognition. Important differential diagnosis from Chapman. I'll be following Chapman 7th edition. Right. So, can I ask candidate 1 to raise your hand, please? Can you do that again, please? Because there is a technical issue for me. I could not. Just bear with me. Yeah, now I can unmute you. Are you listening to me now?
Yep, hi.
Okay, this is a MRCP study. I have given you T2 axial sequences and intentionally just the axial sequences. And what is your diagnosis?
Okay, so in the selected images available, there appears to be a filling defect in the left portal vein.
Anything else, please? Hint, it is too obvious. Hint, if you see a CT scan, you will pick it up in 1 second.
Okay, so I can't see any focal hepatic lesions. Is it generalized hepatic steatosis?
Okay. So what was that?
Air.
Air. So this is pneumobilia, isn't it?
Yeah.
So the point which I am making is that if you go back, you see there is pneumobilia here. But the eye see what the mind knows, because on a T2 weighted sequence, you have not seen it. So you found it very difficult. On the other hand, on a CT scan, it was very, very obvious. So this is an example, and I'll take it further on this, where you have to, I use the word, you have to stretch your imagination, right? And you will find everything very easy. So candidate 1, you can keep yourself unmuted, but in the first, let's say 10 minutes or so, it's going to be more of a lecture type of a mode. But there are any questions I'll ask you. There are no films.
Okay.
Now, you see on your slide, there are 3 types of contrasts, and the concepts about these contrasts are very important for the exam. And this is the difference between a safe radiologist and an unsafe radiologist. It's a black and white thing. If the examiners find you unsafe in the exam, you will be penalized for it. And that, you might fail because of that. So, so the point is, barium, gastrographin, and low osmolar contrast agent can be used in GIT, right? So, take-home points for esophageal perforation, use low osmolar contrast agent. If you use barium, what happens is barium goes out. For example, if the barium goes into the mediastinum, later on it will sit there. It might cause fibrosis. You don't want barium to, if there is aspiration, you don't want it to go into the lungs, where again it can be, it can remain there and cause fibrosis, etc. Though it is not as dangerous as gastrographin. So point to remember that gastrographin, if it goes into the mediastinum, there is a esophageal rupture, no issues. But if it goes into the lung, oh, that is problem, because there will be, you will produce pulmonary edema. So the best thing is to use low osmolar contrast agent. Now, if you see here, this is VisiPake. There can be many, OmniPake, etc. And on some of them, if you see the word oral use is written there on them, so they can be used intra-arterial, intravenous, as well as oral. Now, for upper abdominal GI perforations, you can use gastrographin. So sometimes what happens is, if the perforation is not visible, we can use gastrographin, particularly, let's say, a post-op case, surgical anastomosis, leak, and things like that. So here, if you say barium, it's a blunder. You are unsafe. So remember that. You have to use gastrographin there. Now, another use of contrast agent is for equivocal small bowel obstruction. So you can use barium, but these days, most of the people, they use gastrographin. And one of the techniques which is written here is from one source, but there are so many other techniques. My experience with gastrographin is that if there is too much fluid in the bowel, the gastrographin might become diluted, and then it is not all that effective to diagnose subacute obstruction. Barium, on the other hand, will not be diluted. Please also remember that there is no concept of barium converting an incomplete obstruction to a complete obstruction. There was a lot of debate in, let's say, 30, 20 years ago, where surgeons used to say that barium can convert a incomplete obstruction to complete. Our literature does not agree with that. Gastrographin, some people think, is sort of therapeutic also. Again, controversial, but some people think like that. So both of these you can use. Now, as far as large bowel obstruction is concerned, for equivocal large bowel obstruction, or you can use gastrographin. For pseudo obstruction, I will tell you what is pseudo obstruction. Again, you can use gastrographin. For post-surgical use, you can use gastrographin. Now, post-surgical is a very important thing. Never use barium once again. So please remember it like this, that if the contrast has, you are worried that it might go out of the lumen, don't use barium. That's the take-home point. What is pseudo-obstruction? I'll come back to this. As far as acute abdominal series is concerned, when a patient comes to A&E, we do a supine X-ray abdomen, and we do a PA erect film. On a PA erect film, gas below the diaphragm is better seen. Classical teaching is that the patient should be in an erect posture for about 10 minutes time before you should take a film. But in the real world, I think we just take it. And so this is an erect film and this is a supine film. Please also remember that previously, because now is the world of CT scanning, so our threshold to do CT scans is extremely low. And previously there were multiple films which were taken. Having said that, examiners still can grill you on those films. And the scenarios which they will give you is, for example, you will say, I will do a CT scan. They will say, what if the CT scan is not working? So classical exam question is, this is a patient of, a suspected patient of Pneumoperitoneum. The patient is not well enough to stand. The patient cannot take a erect chest X-ray. What will you do? This is a classical viva scenario. You will say, I'll do a CT. They will say, no, CT is not working. What will you do then? So the answer to that is a decubitus film. So this is how a decubitus film is taken. And this is, the liver has to be upside. So the left side down decubitus. And the concept is that the free air will be in between the lateral abdominal wall and the liver. Now, what is the use of an erect film? Now, this is from the guidelines of Royal College of Radiologists. There was a booklet at that point, 2007, which says that consider erect film if supine X-ray is normal or there is strong clinical suspicion of obstruction. Now, erect film, when we were, 30 years ago, when we were learning radiology, there was so much literature on erect film, and volumes were written on erect film and how to diagnose intestinal obstruction, etc. That concept you should still know. In your real world, you will never use it, particularly in UK, for example. But having said that, in the exam, you should know that concept. What is erect film used for? So, for erect film, the main role of erect film is intestinal obstruction, and I will come back to this. I also want to introduce you here to a tool, which is a beautiful tool, iRefer, produced by the RCR. It is available for members. And basically, there are algorithms there for various kinds of clinical scenarios. And examiners will ask them. Please remember, they ask these questions. And between the line, there are many things written here which they might ask. So let's go through as far as acute abdomen is concerned. This is G14 in your iRefer. Acute abdomen with suspected bowel obstruction, and they are saying that you should do CT or X-ray. X-ray may occasionally be helpful in limited cases of large bowel dilatation, such as known sigmoid volvulus or ulcerative colitis with suspected megacolon. Both of these are classical viva questions. Remember this. Both of them they will ask you in the viva. Sigmoid volvulus take-home point is a plain film diagnosis. And the examiner is going to ask you, once you diagnose it on a plain film, what will you do next? And your answer will be, that's it. As far as imaging is concerned, you will just tell the surgeon that this is your diagnosis. There is no role of doing a CT. You should be confident enough. Secondly is toxic megacolon. If it is a known case of ulcerative colitis, your eyes should pick it up. Having said that, in the real world here, CT can be done because, an associated perforation, etc., can be picked up on CT much better than an X-ray. But these two questions are exam questions. So, of course, CT, the threshold is very low to CT. What is the role of contrast enema? Water-soluble contrast enema is an alternative if CT is inconclusive. So, of course, water-soluble enema means you are targeting the large bowel there. So, all of this, whatever is written here, I urge you to read carefully, and each line can save you in the exam. Now, this is acute small bowel obstruction confirmation and assessment of level. So, what is X-ray? X-ray may show if bowel obstruction is present, but cannot exclude it or determine the underlying cause in most cases. So, the maximum an X-ray can do is there bowel obstruction or not, but the level or the cause might not be picked up. CT is much better there. Having said that, look at the role of contrast studies. If suspected small bowel obstruction due to adhesions, I will come back to this point, adhesions. A water-soluble contrast study is a good predictor of resolution without operation. Now, this concept is asked in the exam. Now, please remember that the most common cause of small bowel obstruction are adhesions. Number one, concept number one. Number two, 80% of them might resolve themselves. So there is a role of what we call, monitoring the case. And for that, if you do a water-soluble study, gastrographin, if it passes through, then means that there is no need of surgery. Now, next, MRI may be considered in pregnant women avoiding ionizing radiation. Important concept. Again, can be asked in the exam. Then, ultrasound is helpful in gasless abdomen. So, there are many conditions in which a patient can have a gasless abdomen and have intestinal obstruction. So, ultrasound can be useful so that it will give you, the loops of the bowel will be full of fluid and you can pick it up. And similarly, it can be very useful in children. Again, it can be a viva question. And ultrasound can also help to see if there is peristalsis in order to differentiate between, functional ileus or obstructive ileus. So these concepts are extremely important. Now, so this is a potential exam film. The examiner can show you a film in which there is gasless abdomen, but the clinical will be the patient has got acute symptoms. So these are the causes of a gasless abdomen. Fluid-filled bowel is what we are talking about. So the patient has got complete obstruction, but it is full of fluid. That's why there is no gas. So remember this. And finally, again on the RCR, I refer small bowel obstruction, low grade or intermittent. And here, intermittent means what we call subacute, low grade, intermittent, subacute, all are words which can be used interchangeably. And what happens is that you can do other kinds of studies like CT enterocolysis and CT enterography, MR or MR. I will come back to these when we will cover small bowel. Okay, ST1s after the exam, which is after October, we will go into a phase where we'll go back to the basics and go back into details. So today, for example, I'm not going to teach you how to read a X-ray abdomen. All ST4 know it, but I am sure ST1s don't know it as well. So we'll go back and we will design some curriculum for ST1 level. So this is the protocol to see a plain abdomen. A few measurements for you to remember, and what are the criteria for various parts which are here. One thing which I want to emphasize is pseudo-obstruction. Now, pseudo-obstruction is an entity which you will see in old age patients, and these patients will come to you with, horrendous looking plain X-rays, and you will see on PACS old films, which will tell you that this thing was there since ever. And these patients are usually bedbound. They might come to you from care homes, etc. And all of these rules, they don't stay, they don't hold for them. and up to 22 centimeter bowel is reported, dilatation. So these, I will, all of you, I think, know these, but this was just for revision. Okay, key exam tip. Key exam tip is, most important exam tip about plain abdomen is, when you see a gas focus on the plain abdomen, ask yourself, is it in the bowel? Is it outside the bowel? And very, very important for the exam, is it in the wall? Is it in the, what we call mural? And again, cases will come in this category. So within the bowel, it can be within the stomach, small intestine or colon. Outside the bowel, it can be under the diaphragm, it can be within the liver or any other viscera, it can be in the bile ducts, the portal vein, there can be pockets of free air, it can be in the retroperitoneum. All of these are exam cases. And these are again exam cases. So here, the gas is present, but this gas is present in the wall of the viscera. And again, they will come in the exam. Is it in the bowel loops or in the stomach or urinary bladder or gallbladder, etc. So I'll show you examples. Now, another exam tip is, when you are describing anything like an intestinal obstruction type of a case, you have to tell the examiner, number one, which segment of bowel contains the gas. Number two, is the caliber or dimension of the segment more than what is allowed? Number three, what is the distalmost point the gas has passed in the intestine? So is there any gas in the rectum? This should be part of what we call pertinent negative or positive. So it should be part of your description. There is gas in the rectum or not. Please remember the concept that when there is a complete obstruction, it takes about 24 hours or so for the gas to absorb distally. But after that, there might not be any gas in the rectum. So it becomes an important pertinent point, though the specificity is quite low. This is extremely important for the exam, and it is important even for your rapid reporting, because there is a case which comes again and again in the exam, and which is toxic megacolon. And here you can see the mucosa, outline of the mucosa of the transverse colon. So I will show you the examples. Okay, so with this background, candidate 1, your film. Patient has got acute abdomen presentation. Over to you, please.
This is a frontal radiograph of an adult patient. There is a tubular gas-filled structure in the midline, which would be in keeping with the transverse colon. The mucosa of this bowel looks a bit inflamed, and I would consider colitis as part of the differentials. I can't see any fluid.
Okay, good. Now, you have inferred that there is colitis, and you have said correctly that the mucosa is inflamed. This is your inference. But on which grounds? I want to hear that descriptive, should I say, those descriptive terms. You have concluded correctly, but how have you concluded that?
So the mucosa appears a bit irregular and thickened compared to usual. Mm-hmm. And the irregularity combined with the abnormal thickening.
Okay, okay, that's fine. I'll take over. So if you see here, normal transverse colon has got haustra, and this thing should be in your mind, in your description in the exam. Loss of haustra. Remember that. The loss of haustra. Number 2 is, if you see, these are thumbprints, right? Loss of haustra, there is thumbprint here, and maybe a pseudopolyp. So the point is, let me show you another case. Rather, these are two different cases. Again, you will see that there is loss of hostra, complete loss of hostra. This is known as thumb printing, And this thing which is projecting into the lumen are known as, these are mucosal tags, simple as that. So, but this is evidence that there is mucosal thickening. So you will say loss of hostra. If there are thumbprints, there is thumbprint in keeping with mucosal thickening, and there are some, filling defects within the air-filled lumen in keeping with inflammatory polyps. Now, if you see here, megacolon in an adult, so non-toxic without mural abnormalities. Toxic is with severe mural abnormalities. And these cases have come in the rapid reporting, many a times. For example, this is a classical rapid reporting case. It can come in the viva also, whatever. So you have to really develop your eyes on this. And loss of hostra is one of the key things which you have to remember. What's happening here? I just want to hear a radiological sign.
Is it called the string of pearls?
No, if you see here, stretch of imagine, this one, this one, this one, this one.
Printing?
Thumb printing, once again, it's thumb printing. Now, interestingly, this differential was there in the previous editions. Thumb printing is, I just wanted to show it to you again so that you know that this word, it should be in your vocabulary, should I say. And the point is that many things, it's a non-specific finding. Non-specific finding of what? Because basically mucosal thickening. And this mucosal thickening will be seen in the large as well as the small bowel. I'll show you many examples. Please do not think that all cases of mucosal thickening will have thumbprints. Within the small bowel, there might be other signs which we will consider later on. You are in the A&E. This patient comes to you from the hospice. The patient is not very well oriented. A bit of dementia is also there. You have done this X-ray. What are your comments?
Okay, so this is a frontal radiograph of the abdomen in a 92-year-old patient. There are multiple large dilated bowel loops with an abnormal position. There's a large tubular structure which projects to the left and lacks obstructions. My first differential for this will be a sigmoid volvulus. I can't see any free air or gas. The patient still has an intrauterine device, I think, in the pelvis. This looks like it's a sigmoid volvulus as a most likely diagnosis.
Why do you say sigmoid volvulus?
I can't see the prostration patterns in the large dilated bowel loop. The axis appears to project more to the left, and it's more common than cecal volvulus in this, and especially in this age group and in a hospice patient. So with the clinical information.
Okay, your main reason to call it a sigmoid volvulus was that you thought, let me point out, hostra. If you are worried about this loop, there are hostra. If you are worried about this loop, again, there is hostra. And in a sigmoid volvulus, what will happen? This will be a U like this with two loops. The U is not there, inverted U, I mean to say. Anything else?
It could be an ileus.
What will you do next?
So, if they're concerned and the patient has acute abdominal pain, I'll recommend the CT. Right.
But before that, CT is a correct answer. But first thing which they want to hear is, I will compare it with the previous films. This kind of a scenario. where a patient comes from hospice. It's not an acute scenario. These patients, and in your day-to-day practice, you will see them so often if you are working in A&E. You open a previous PACS film and the abdomen will be like this. I'll come back to this point. So this is the CT scan. Unfortunately, I have not given you, the, let's say, recto-anal canal junction is not there. Having said that, everything is dilated. There is no pneumoperitoneum in this case. What will be your conclusion?
So it looks like there's fecal impaction of the sigmoid colon. The sigmoid is quite dilated with upstream dilatation of the bowel, but the bowel wall continues to enhance normally. I can't see any free gas in the abdomen. So my main differential is the sigmoid fecal impaction or fecoma.
Okay, so impaction in these cases, two things are very important. One is anal canal cancers. You have to ask the clinicians to have a look. That's a clinical territory, right? They can have a look. The patient might have an anal canal tumor, which is causing stenosis. So that's a potential viva scenario. Otherwise, in this particular case, there was no anal canal or anything. This is a case of pseudo-obstruction, chronic pseudo-obstruction. And pseudo-obstruction, as I told you before, we'll see in cases where, bed-bound hospice cases, things like that. Because of chronic constipation, they are like this. If you compare it with the previous films will also be like this. And every 3-4 months, they might be coming to your A and E. And in these, the criteria for dilatation is different, as I told you in the table. Up to 22 centimeter has been documented. Having said that, sometimes these patients can also perforate, and I've seen a few where, don't think that it's a completely benign condition, and there will be a time when they will perforate. But the concept of pseudo obstruction should be in your mind. And this is, this thing, chronic pseudo obstruction. And in UK, this is a very important concept, particularly in AN. Okay, candidate 1, this is your last film. Acute abdomen, pneumoperitoneum, yes or no?
No.
So what is it?
Chiodati syndrome, where you have a part of the hepatic flexure projected over the liver.
Okay, that's fine. Now, here what is happening, and this film can be shown to you even in rapid reporting, just to confuse you, where some people might pick it up as pneumoperitoneum. Now, this is what we call interposition of large bowel in between the diaphragm and the liver. And the key thing is that the hostra will be projecting in. Okay, thank you very much, candidate 1, and we go to candidate 2, please. Raise your hand. Candidate 2. Okay, I cannot see candidate 2, so I will go to candidate 3 then. I am unmuting candidate 3. Candidate 3, can you hear me?
Yes.
Okay. This patient has got, are you worried about intestinal obstruction in this case? Which loops of bowel are visible? These are my 2 questions.
I think these are dilated large bowel loops.
Mm-hmm.
I think the caliber of the bowel is within acceptable limits for large bowel. Therefore, I am not worried about obstruction.
Right. Now, if you go back to the basics, this is a very tricky film. Actually, you remember, how do you differentiate between small bowel and large bowel loops? Picture frame is why you are confused in this case. Picture frame is one thing where large bowel loops are at the periphery and small bowel are in the center. Then is Hostra versus Volvuli conniventes.
Mm-hmm.
And these are Volvuli conniventes. These are not Hostra. So that's the key thing. And
Okay.
they are really dilated. And if you see here, this is small bowel. Actually, there might be something here, but if you see, there is nothing in the rectum. So beware of severely dilated gas-filled small bowel. And the teaching point or learning point is to differentiate between Volvuli conniventes versus Hostra. The same case, I am showing you erect film. As I told you, there are no chances of you getting an erect film. But if an examiner asks you this question, this film will help you. So how will you describe candidate 3, this film? You know, this is the same patient, by the way.
So there's quite marked opacification in the sort of mid to lower abdomens, with almost like a fluid level visible across the bowel.
Excellent. And what is this where I am pointing out?
Looks like gas within bowel. So
There is a sign. I'm waiting to hear that sign. And that sign is considered quite specific for intestinal obstruction.
I'm not sure.
Okay, fine, no problem. Now, on an erect film, what happens is that you will get what we call fluid levels or air fluid levels. Air fluid levels. There is a lot of literature on this, so I don't want to go into that. The only thing is that this is known as string of bead or string of birds, string of pearl sign. Now, this is another patient, by the way. This is not the same patient, but just to emphasize, let me go to, okay, there will be another film where I will teach you once again. What happens is, string of bead or string of pearl sign is an exam sign of intestinal obstruction. Basically, when there is significant amount of fluid filling of the obstructed bowel loop, there is limited amount of gas bubbles. Now, these gas bubbles are in between two Volvuli conniventes. So they will give you this kind of appearance. This appearance can be seen on an erect X-ray, or it can be also seen on a CT scan. And when you see it, call it. It's considered quite specific for small bowel obstruction. And this, whatever is on this slide, there are a few viva questions which have been asked in the exam. As I told you in the beginning also, adhesions are the most common cause. These are the causes which you have to remember. Again, this is a viva question. Adhesion 60% is the most common cause. Please also remember the concept that 80% of them might resolve. So this is important. And this is another case from literature, from StatDX, to give you the same concept. This is a supine film. This is an erect film. And on supine film, things look quite normal actually. Well, what is this? You know, if you report it, you will not be much worried. But when you do an erect film, then you pick up this string of bead sign. this tells you what is happening. Actually, there are dilated loops of small bowel and trapped air bubbles giving you this appearance in between the vulvally conventives. And this is the CT of the same case. And it tells you this string of bead or string of pearl sign. So this is important to remember. Okay, candidate 3, your film. This patient is 57 with constipation. Can you tell me which loop of bowel is this? You know, anatomy wise, small or large bowel?
It looks like large bowel.
Excellent, well done. So these are hostra. So this is large bowel. Is there gas in the rectum?
I can't see any gas in the rectum.
Excellent. So what will be your conclusion here?
I think these findings are concerning for sigmoid volvulus.
Okay, but why did you say sigmoid volvulus? Because please remember, sigmoid volvulus, the margins will be without hostra. You know, there are very limited hostra, 1 or 2 in sigmoid, and when it is dilated, even those are not seen. So remember, it's a very important point for your exam. Ahostral margin. This is one of the key things in sigmoid volvulus, right? So this is a large bowel loop, but it is something else. So in this case, we did a gastrographin. And what is your finding?
So there's contrast or pacification within a loop of bowel, which looks like the cecum.
So let me take you through it. This is the rectum, right? And we are going into the sigmoid. Now, as soon as we reach this, you know, this is sigmoid here. This loop is projecting behind it. So what is happening here?
Narrowing.
Excellent. So this is a stricture. And this stricture is in the sigmoid colon. One of the key findings, which are when you do a contrast examination for a suspected, large bowel obstruction, these days we usually use gastrographin. If you use barium, you have to be careful. If you reach a stricture, only limited amount of barium should be allowed to go beyond it, proximal to it. But do you think, what is your final conclusion? What is happening, benign or malignant?
I think this is malignant.
Excellent. And why do you say that?
Because there's shouldering of the...
Excellent, well done. So this is a classical apple core type of a stricture with shouldering and overhanging edges. And this was a sigmoid. So what are the take-home points? The take-home points is that we saw a loop of large bowel. We are not sure which loop, but it has got hostra. So this should not be confused with sigmoid. And actually, there was a stricture there. Okay, this one is for pattern recognition. So this patient is post-cholecystectomy, and I am not worried about this. Is there any abdominal visceral abnormality? Over to you, please.
The spleen looks enlarged.
Excellent. So this is the teaching point here, and this has come in the exam quite often. Because please remember that one of the protocol-wise, you have to look for any visceral, megaly or things like that. And here, this is the spleen, and this spleen is enlarged. So this is the psoas, this is the psoas, and this is the kidney. Part of the kidney might be visible here, but this thing is the spleen. So the CT scan of the same patient, where you can see splenomegaly and lot of lymph node. an MR of just to show you the same thing, and plain film of another patient. Though I have written it here, patency capsule, but candidate 3, can you please tell me what exactly is this? What do you understand by this patency capsule? Have you ever seen it?
No, I've never seen it before.
Okay, so let me tell you. Now, these days, to evaluate the small bowel, the gastroenterologist also can do video endoscopy. So they have got a small capsule which has got a video inside, and they ask the patient to simply just, gulp it down, and it goes through the small bowel and produces a video, and later on they evaluate for this. Now, before that, they have to make sure that there is no stricture. So usually they might do an MR enterography, etc., that there is no stricture. But even whatever we say, they will do. This is made up of a radiopaque material which is dissolvable. It is biodegradable, but initially it is radiopaque. So they ask the patient to take it, and then they take plain film, let's say the next day, and it has to go beyond small bowel, and that is a indicator that there is no stricture. On the other hand, if it stays inside, means there is a stricture. And if there is a stricture and they have done capsule endoscopy, then they will have to do surgery because of that. So I just wanted to show you, because in this era these are being used very often, so all candidates should know and the concept behind it. Patency capsule. Candidate 3, over to you. Anything in the soft tissues? Do you see anything?
So frontal radiograph of an abdomen, there is increased soft tissue density bilaterally, but predominantly on the left side of the abdomen.
Yeah. So you have picked this up. Very good. Well done. Now, what is your differential?
It looks almost house.
So it is very rounded, right?
It is very rounded. In that location, it could be a adrenal gland mass, or
so now you are talking about what we call a differential, and your mind is absolutely working brilliantly, because now you have seen that this is kidney. Now the lesion is here. So in this region, your thinking is what is there, and the first thing was spot on. You are worried about adrenal. What else can you be worried about?
So it could be a mass arising from the upper pole of the left kidney.
Excellent. But if you stretch your imagination and see here where I am pointing out, right? Maybe you can see the outline. So good thing, good thinking, but less likely. Okay. What else?
Pancreatic lesion.
Excellent. And what kind of pancreatic lesion comes to your mind?
As big as that. So a pseudocyst.
Brilliant. Well done. So this was a pseudocyst. So well done, candidate 3. We will go to candidate 4. Well done. If you see, this was the pseudocyst, and you can see that this is what we call the lesser sac. The stomach is here. It is displacing it anteriorly. Well done. Now, candidate 4, can you raise your hand? You are with us?
Yes, sir.
Okay. Now, spot diagnosis. I am not at all interested in all of these radiopaque foci, but overall picture, give me a diagnosis. What do you think about these loops of small bowel? What is happening?
There, I can see there is a obstructed small bowel obstruction, and it shows the regular sign.
Okay, regular sign. So, for example, here you might have picked it up, and if I no, there is no regular sign. Anything else comes to your mind? Where are these small bowel loops? Where, you know, anatomically speaking, this is the abdomen in cross section, transverse and longitudinal. Anything comes to your mind?
In the center of the abdomen.
Excellent. So, conclusion.
So it's small bowel obstruction with the
You know,
yes,
I like that when you said that they are in the central part of the abdomen. So,
yes.
hint is that I like that. What comes to your mind?
So it's just a small bowel obstruction, which in the center of the abdomen. And what else? No. What? No, I'm not getting that.
I'll take over. Don't worry.
Yeah.
This is ascites. Now, this kind of ascites has come in the exam. I remember there was a long case actually. Can you imagine a long case which came, I think 2 years, 3 years ago? It was a baby gram. And on that, one of the key finding was that this was the finding on a baby gram. Sometimes what happens in ascites is that because there is too much fluid, the small bowel loops which are gas filled, they float centrally. And this is the picture which you get, floating small bowel and centrally. This is another case where small bowel loops are here in the center. And this CT scan tells you what actually happens. There is a lot of ascites and these loops are in the center. So I'm not saying that all cases of ascites will look like this, but you have to remember, as I always say, the eyes see what the mind knows, that this type of ascites can be asked in the exam. Okay, candidate 4. Anything abnormal here?
Okay, that's the erect abdomen, in which I can see there is continuous diaphragm sign.
No, don't worry about this.
Okay, so
Anything in this?
there is a soft tissue mass I can see in the epigastric region.
Okay, you look carefully. Of course, maybe the projection is not very, very clear. But having said that, you have picked up this thing, right? What comes to your mind? What can you describe it?
Yeah, there is a soft tissue opacity and the left under the left heparin diaphragm region, which is irregular in margins. It's not. I can't see any calcification in it. It's located in the area of the.
Okay, so this I'll give you a very interesting hint. I think this is from BMJ, and this is a case report. This X-ray was done at Heathrow Airport, and this patient, according to that case report, was then spending time in Chelmsford jail. Now over to you.
Ampules.
Yes. So if you see here, this is a body packer or a drug mule. So what they do is that they use, either they use latex gloves. For example, these are fingers, of the latex gloves, which are tied together. So what happens is that the beam of X-ray, if you see, it gives you a crisp and sharp outline where I am pointing out. This is the outline of it, or they can also use condoms. So this is what they do. This is body packer, and this is another case from literature. And this is, we also call them drug mules. And this is a better quality picture, which gives you the same appearance. Look for this. It's a very, Aunt Minnie type of, if you see it, you see it. And if you don't see it, you've never seen it, you will never pick it up. So it is another example. Candidate 4, this is your last case, and then I will go to candidate 5. So be ready, candidate 5. Just point out candidate 4, this calcification, where is it? Are you with us, candidate 4?
You need to unmute.
I have to unmute her. Okay. So now I have unmuted.
Yes, sir. So that's the calcification is seen in the pancreatic region. That's the pancreatic calcification.
Excellent. Excellent. That's fine. Because of time factor, I'll carry on. So if you see this calcification, classical, and calcification which goes over the spine, classical for pancreatic calcification. And pancreatic calcification has got a differential diagnosis. And chronic pancreatitis, vascular calcification, pseudocyte calcification within a tumor. This is very important for you to remember. And I urge you to read the details of 8.32. I don't have time to go through it because it can save you in the exam. For example, adenocarcinoma of the pancreas, which is the most common pancreatic tumor, unusual to have calcification unless there is chronic pancreatitis. So that's a nightmare scenario where a chronic, please remember that pancreatic adenocarcinoma is prone to develop in chronic pancreatitis, but neuroendocrine tumor usually will show calcification. So this is a point to remember. Many, things you have to remember. And many of these things you have to remember because it can also become a sort of a long case. So read this differential with great details, should I say. Candidate 5, raise your hand, please. I cannot see candidate 5.
It says candidate.
Candidate 5.
Yeah.
Okay. Yeah. So now I have got you. Are you with me?
Yes. Can you hear me?
Okay. Just, yeah, we can hear you. And please, it's quick because we are going to crack on. Where is this calcification? This is just to develop your eyes.
Intraperitoneal.
You see, it's very well defined. It is within a viscera. This is what we call a visceral type of calcification.
So then looks like within the gut.
Okay, something which can be so large among the viscera.
Large gut.
Anything else? This patient is quite, clinically speaking, quite good.
Where else could it be?
Think gynae.
Okay, so it can be like fibroids, calcified fibroids.
Yeah. So these are, please remember that Fibroids, you know, the uterus can go all the way up to the diaphragm and they can be huge and they can calcify. So this is the visceral type of calcification. And what I'm showing you is quickly just, you know, pattern recognition. So nothing more than that. Is there any organomegaly?
Yes, looks like on the right side, upper abdomen, so most likely liver.
Excellent. So these kinds of cases can come in the exam, and then from here, once you pick it up, the ultrasound might be shown to you or something else might be shown to you. Where do you think is this calcification?
Okay, so this can be either within the liver.
Excellent. So this was within the liver, which is a very enlarged liver. And this was actually metastasis post-radiotherapy. So they have calcified, but there. Metastasis, you see this metastasis? A calcification within a mass. So it can also happen. Where is this calcification?
Okay, so this is in the left upper quadrant. So I can think of a spleen, calcification within the spleen, or I can think of if a large mass within the adrenal, but it's a bit high and more laterally. And I can think of something within the pancreas.
Okay. Same case.
Okay, so this is a barium contrast meal, which is opacifying the stomach, which appears to be a narrow lumen, and there is cross thickening. This is like a typical appearance for Limnitis plastica.
So where is that calcification?
So that calcification would be within the stomach. So it.
Yeah, actually you can see it. You see from here to here is that thickening, mural thickening. Now you can see. If you go back, this is that calcification, and look at the shape of that calcification. It goes with the stomach. Very unusual case. I'm not expecting that you will pick it up, but just to develop your eyes, that sometimes these kinds of things happen. And the basic thing is that this is Limnitis plastica, and we will cover it in the next session in detail, where there is loss of distensibility, and you can see that there is mural thickening also. This calcification, what do you think?
Adrenal or kidney?
Adrenal, very good. So this is adrenal calcification. Adrenal calcification is again an exam calcification, because then the differential diagnosis will be asked. And this is the differential diagnosis, which you can cover in 9.3. Where is this calcification?
So it's in the left upper quadrant as well. So pancreas, a pseudocyst, calcified pseudocyst, or.
Excellent.
Okay.
So this was a pancreatic pseudocyst, and this one is sort of calcified. Where is this calcification?
In the region of kidney, left kidney.
Look at the shape.
Quite difficult to actually.
Do you see that? How is the shape here? There is something here, snake, serpentine, tortuous. What comes?
Could be vascular calcification.
Yeah. So in this region, what kind of vascular calcification? Actually, you will see it very commonly in old age patients.
Splenic artery?
Yes. So this is, please remember that splenic artery is very tortuous, and it is classical like this, that where you will see this calcification as well as its tortuosity. What is this?
So this could be aneurysmal aorta calcified.
Yes, and this is an aortic calcification of aortic aneurysm. What's happening?
this most likely is calcified gallbladder,
What do you call this thing?
porcelain gallbladder.
What do you advise? What will you advise? Why work with
This is worrisome because it mostly develops gallbladder carcinoma, so it would be urgent to do a CT scan.
Okay, that's fine. And even you see on the CT scan, you will see the same thing. You might see a tumor, might not see a tumor. Even if you don't see a tumor, what are you going to advise?
So this has to be like removed there and then. So cholecystectomy.
Cholecystectomy, you have to advise a cholecystectomy. If you see latest literature, you know, the original literature was quite emphatic about development of carcinomas. Some of the latest studies, they are not all that supportive. Having said that, the concept stays. You know, the percentage of patients who develop carcinoma has reduced in latest literature. Having said that, the answer is in the exam and in your clinical practice, you will advise a elective cholecystectomy. This is your last case, and then number 6 should be ready. If you can tackle it as a viva film, and I'm listening to your description, please. Over to you.
Okay, so this is a plain X-ray abdomen frontal view of an adult patient. I can see multiple dilated bowel loops predominantly in the center of the abdomen. In the pelvis parts, one of the bowel loops is like I can see the wall in and outside as well. So I'm suspecting it to be a regular sign and pneumoperitoneum in this one.
Okay. So anywhere else, do you see any signs of you know, what we call pneumoperitoneum? Your diagnosis is correct.
Okay, I can, I mean, other than the regular sign, within the hepatorenal angle, Morrison's pouch,
Excellent.
there
So
is a triangular cap sign.
Okay, well done. You can mute yourself. I'll take over, and candidate 6 should be ready after this film. Now, if you see here, you know, in your exam, pneumoperitoneum will always be shown on a supine abdominal film. In an FRCR level, nobody is going to show you a chest X-ray for that. So regular sign is one of them, where you see outer as well as inner surface of the small bowel. I warn you, you know, when small bowel loops are dilated and distended, and they are projected over top of each other, at times we get what we call a pseudo regular sign. So you might confuse it. Now, so this is regular sign. Then within the you know, now we are going into the world. What are the signs of pneumoperitoneum on a plain film? And you can see at times gas accumulated. For example, here it is. Subhepatic region, you can see this gas here, it's known, and there is gas here also. So these things should be in your mind. Now this is free gas under the liver, and this is an exam sign where falciform ligament is outlined by the gas. I'm sure all of you know this, and you have to point it out to the examiner that this is what it is. Okay, candidate 6, can you please raise your hand? So I have clicked you, and I hope it's worked for you. Are you with us, candidate 6?
Yeah.
Okay. This is my favorite film. Over to you.
Okay, so it's a frontal chest radiograph as well as a abdominal radiograph, which is demonstrating there's no free air under the diaphragm on this abdo X-ray AP ract. However, I can see there's a dilated lunar bulbs in the abdomen. This in the center of the abdomen, there's a round gas shadow.
You have picked up this shadow. Well done.
Yeah. and can't see any. There probably is a regular sign, a hint of regular sign adjacent to this shadow. Not convincing though.
So,
This film is not. I mean, ideal, but I would have liked to see the little lateral walls of the abdomen as well as the stomach to see whether there's a gas under the liver or falciform ligament is marked. Also, I can see the probably gas.
okay, I'll stop you here. Now, basic thinking on a plain abdomen film, as I told you, when you pick up any gas, you have to ask yourself, is it in the lumen? Is it outside the lumen? Or is it in the wall? You have picked up this rounded shadow. Now, if you see here, this is the transverse colon, right? What is this?
That's stomach.
That's stomach. So is it in or outside?
That's in the
Can
lesser.
it be stomach?
That's outside, extraluminal.
So what is the conclusion?
So it's a retroperitoneal gas in the lesser sac, most likely.
In the lesser sac, or okay. So this is the CT of the same case, and do you see any pneumoperitoneum?
There is pneumoperitoneum.
Look at this one.
Yeah, there is pneumoperitoneum, quite large amount
Is
of.
it gross pneumoperitoneum?
Yeah.
Agreed?
Mm-hmm.
Where is it sitting? It is sitting here in the center, and this is what we call the football sign or the cupola sign. Here, what happens is that there is large amount of free air, but it sits in the center part. And the beauty of this film, and this is a classical exam film, that this gas, you can see that it is away from the stomach. It is not, and this is large amount of gas. So in the central portion. So this is football sign or the cupola sign. This is a cupola. Okay, over to you. Where is this gas? What's happening?
So in this plain abdomen X-ray, I can see gas outlining the psoas muscle as well, and kidneys. So kidney is quite delineated. So it's a retroperitoneal gas.
Yeah.
Yeah. So patient has a surgical procedure. So I'm just wondering what kind of so retroperitoneal gas could be because the retroperitoneal structures hollow viscous which are ascending.
Why do you say so? My question is more basic. Why do you say that there is retroperitoneal gas? So the learning points are, where do you see retroperitoneal gas?
Outlining the psoas, in the outlining the kidneys.
Excellent.
And it should be in the deep pelvis, outlining the rectum as a part of the rectum, which is retroperitoneal.
Outline will very difficult to see.
Yeah,
that.
lesser sac you can see in lesser, but obviously in on plain film it's difficult to pick up.
Is lesser sac by definition retroperitoneum? You remember lesser sac has got a connection with the peritoneal cavity, so that's a peritoneal.
Okay,
If you see here, let me take over. Now, this is a very good film to develop your eyes on where can retroperitoneum be. So, of course, it is outlining the kidney, it is outlining the kidney, outlining the psoas, right? But other things which you have to remember is, this is the hemidiaphragm. The posterior portion, posteromedial portion of the diaphragm is touching the retroperitoneum. Another sign which is now if you in your exam you pick it up as a retroperitoneal gas, of course you are pass, but you want to get more and more marks, and the more fine touch is that you have to pick up the findings. Another beautiful sign is this one, which we call large bowel regular sign. If you go back to your anatomy, remember that the ascending colon as portion of the ascending colon and portion of the descending colon is in the retroperitoneum, right? And when that portion is outlined by gas, you see this is portion of the descending colon, and there is a large vowel regular sign. So this is another sign. If you pick it up, you know, as an examiner, I'll give you half a mark more, and you have to take it so that you know, you can compensate for any other fail. So causes of Pneumoperitoneum, you can also add it. I think this is from Radiopedia, if I'm not wrong. Now, another point, there are two specific questions I want to ask. This is a case of, again, Pneumoperitoneum. You can see, look at this diaphragm, the posteromedial portion that is outlined. What is this in the spine? What's happening here? So there's a bit of story, you know, what is the story here?
The patient has got degenerative disc disease, and then there's a spinal fusion.
No, not at all interested in the fusion, etc. What is this high density? You see this high density?
Yeah.
And this high density is actually outlining maybe, you know, maybe nerve roots here also.
Calcification of
So hint, story, and the story is that this is something which was done in 1980s. Okay, so in that era, we used to do myelograms with a contrast agent, which was known as myodil, and it could stay there forever like this, and there was a lot of toxicity, etc. Please remember that these patients are still around; they are still alive, and if you see it, it's a quite of Aunt Minnie type of an appearance. Nothing else can give you this kind of appearance.
Hello?
Even the nerve root is out. Rapid reporting. Yes. Hear me.
Yeah, I can hear now. Sorry, there was a lag. Sorry, yeah, connection lag.
Okay. Now, rapid reporting, normal or abnormal?
Abnormal. There's a gas underneath the right hemidiaphragm. So it's peritoneum.
And do you see anything in the chest? Gas anywhere?
Just trying to look for the mediastinum.
Excellent. Your thinking is absolutely correct, but where is it?
On the right side. In fact, going all the way on the mediastinum. Yeah, there.
Not here. Actually, maybe it's not projecting for you very clearly, but actually this is where it is. You can see this mediastinum. The learning point here is just the same thing. If you see, this is the posteromedial portion of the hemidiaphragm. When it is outlined by gas, and when this is outlined by the gas, anatomy is that this can be retroperitoneal gas. If you see here, this patient has got outline of the swas like this. Now, I will show you a case. I think, sorry, I have shared the. So I'm showing you this case just to develop your concepts and your eyes on the concept of pneumomediastinum and Retroperitoneum, etc. Now, if you see here, number 6, can you see a CT scan?
Yeah, I can see.
Okay. So I'll just give you what I wanted to show here is that if you see here, you have got pneumomediastinum here. Now, what is happening? That pneumomediastinum. Now, do you see how it is going just along the crust of the diaphragm?
Yeah.
And now it is going into the peritoneal, the retroperitoneum. It is outlining all of these retroperitoneal structures. So the kidney and the psoas, and this is what you see in the plain film. Another thing, another concept which I wanted to show you. You remember that I told you that portion of the ascending and portion of the descending colon is in the retroperitoneum. So here is the proof that portion of this ascending colon is outlined by the gas here. So gas bubbles are going, and similarly, if there was gas here, it would have outlined. So let's see the coronal of this one. And now, this is, of course, the colon, ascending colon, gas here.
Yeah.
And then this was the learning point, under the diaphragm. And another thing is that gas can go from the mediastinum into the retroperitoneum, also the peritoneal cavity, and vice versa. Do you see how it is going superiorly? So through this hiatus, and now it is going into the mediastinum. So I'm just showing you to develop your concepts that what exactly can happen. Okay, now I will go back to my number 6. Can you see my screen now?
Yeah.
So so this is another case of mediastinum with Retroperitoneum, just to develop this concept that it can go from up to down or from down to up. Both ways it is possible. Okay, what's happening here?
So there's a liver shadow, which is obviously obvious, and then there's a gas. There's a gas shadow, whether it's biliary or I think it's not biliary. It's outlining the liver. This shadow.
Okay. This thing is something which is a point of discussion. But if you see these loops of bowel,
yeah, they're dilated and gas filled.
See anything here?
There's basically I can describe this film. It's a abdominal film which is showing dilated loop bowels with the gas in the wall of the bowel, pneumatosis, and then probably the gas in the portal venous system, which is
conclusion.
Conclusion is ischemic bowel with portal venous gas.
Excellent. So here, okay, thank you. Number 6. Number 7 is next. Please be ready. If you see here, there is gas within the wall of the bowel, and these are dilated loops, so must be paralytic. And with that, there is what we call gas in the portal vein, Pneumatosis intestinalis. And one of very interesting ones, you see, benign causes, 12 patient versus life-threatening cause. One thing which I want to warn you is this one, idiopathic. Idiopathic pneumatosis intestinalis is a very important exam case. I don't know how many of you have seen it in your clinical practice. We have got 2-3 very good cases in our hospital which come every few years. And these patients will have bubbles of air in their small or large bowel within the wall. They've got a pathognomic radiological findings. And if you see it once, you are never going to miss it. If you don't know it, you are never going to pick it up. What happens is that these bubble of idiopathic means we don't know what has happened. And these bubbles, they might burst, and these patients might come to the hospital with Pneumoperitoneum. But this Pneumoperitoneum is what we call Pneumoperitoneum without any peritonitis. So you have to understand this. So this is a very important exam case. Gas in the portal vein has got a differential, which is here. All of you know this, infarction, etc. So this is a case of gas in the biliary system. And gas in the biliary system is nothing important. You know, gas in the portal vein is very important, but gas in the biliary system is not all that important, because one of the usual cause is incompetent sphincter, which can happen in old age. 7, are you with us? Can you raise your hand? So, can you hear us?
Yes.
So, in this case, there is ischemic bowel. Because of time factor, I want to crack on. You tell us the findings.
Okay, so there is small bowel obstruction with dilated loops of centrally placed bowel, and there is some gas within some shadows within the projected over the liver, in keeping with portal venous gas. And there are some on the left-hand side. There's also some air between bowel loops, so likely to be some pneumatosis as well.
Right. So if you see here, this, if you trace this, you can see a bit of air within the wall. When it is projecting tangential to the beam, you will see it much better. Now, if you look carefully with this finding, there is a bit of regular sign here. You can see the serosal surface. So this is a regular sign. When they will show you ischemic bowel, like this on a plain film, keep looking for signs of pneumoperitoneum. When there is ischemic, when there is ischemic bowel, there will be obstruction and functional obstruction, and with that, there can be pneumoperitoneum. Well done. Just name this finding. What is happening?
So it's a gastric volvulus?
So where is this air?
Yeah. Oh. No. So there's air around a dilated hyperdense structure in the...
That is the stomach, you were right.
Yeah, stomach.
The point is that where is this air?
So the air must be peritoneal.
Can it be within the wall?
It could be. So that could be a pneumatosis of the stomach.
Yes. Now, what is the concept? The concept is that, by the way, this is a contrast examination. Part of the contrast has gone, there is a bit of gastric outlet obstruction. So the concept is that when there can be sort of obstruction or dilatation, sometimes what happens is that to develop your concepts, basically think like this, that pressure, intraluminal pressure has increased, and there is a rent or in the mucosa, and air goes inside. When air goes inside, it will go into the wall. So secondary to any kinds of obstructions, you can get a bit of pneumatosis. So this is a case of pyloric stenosis, which has presented like this. This is a slam dunk case. What is your diagnosis here? Around the stomach, what is happening?
So there's pneumatosis within the stomach.
Right.
Wall. There's also small bowel obstruction, and there's portal venous gas as well.
Excellent.
So
conclusion?
So it's bowel obstruction secondary to with small bowel ischemia, pneumatosis.
Are there any signs of small bowel ischemia visible to you?
Actually, no, the small bowel loops are all enhancing normally.
Right.
So pneumatosis secondary to small bowel obstruction.
Right. So this concept is similar to the one which I was showing you in the previous film. This patient was very interesting. This patient came to our A&E and actually walked into the A&E with chest pain. And they asked for a CT, and then we picked up something, dissection and things like that. And we then did the abdomen. The point I'm making here is that this patient actually had small bowel obstruction. There were no signs of ischemia. You have to pertinent negative or positives in the exam. I will come back to this when we will do small bowel. Regarding ischemia, what should be your pertinent negative and positive? I'm not showing you everything here. This patient had obstruction. And with that, you can see this, the string of bird or string of pearl sign. And because of that, the gas, the same hypothesis has gone into the wall, actually has also gone into the wall of the stomach. And this patient was clinically quite well and radiologically speaking very bad. Ultimately did surgery. Irony is that the patient developed some complications, and I think 3 weeks down the road he died. So in any case, this is another mechanism of gas going into the wall of the viscera. Okay, this is the Aunt Minnie case which I was talking about. Over to you.
Okay, this is a coned-in abdominal radiograph. There's a dilated loop of bowel with multiple locules of gas within the bowel lumen. And there's some locules of gas also near the inferior portion of the film that seem to be sort of, just projecting from the bowel wall.
Right. So what do you think is this?
So it could be multiple diverticuli?
Okay, if you look carefully, diverticuli will not look like this. These are unknown. These are grape-like, bubble of airs, bubbles, multiple air bubbles, which diverticuli will never project like this, particularly on a plain film. And the key thing is that some of them, when you see tangentially, they are projecting outside. Now, if you see this contrast examination, it will tell you what is happening. These are multiple air bubbles. Now, develop your eyes on the finding here. Tangentially, you can see that there is an air bubble here, and look at them. They are projecting beyond the wall. So this is what I call, the idiopathic or primary pneumatosis intestinalis. You remember this differential diagnosis? Idiopathic, benign causes. And idiopathic also tells you that we don't know the etiology. And please develop your eyes on this. And I've got a very good case on CT also, these ones. But of course, for that, you need a software, a DICOM viewer to pick it up. And so remember this. And when these air bubbles will burst, the patient might develop pneumoperitoneum. without any peritonitis. So we use that word pneumoperitoneum without peritonitis. The patient will be absolutely fine. So this is idiopathic pneumatosis intestinalis. Classical 2B film. I've been very kind as an examiner to give you this history, but because of time factor, I have given you this history. But this is a classical, very good 2B film. Over to you.
So, in the epigastrium, there are multiple gas locules, and there seems to be one large, sort of well-defined lesion bordering them, and these are in just below the rib cage, so it's at the level of the pancreas. There's no evidence of bowel obstruction, so these features, the differential for this could be a large pancreatic pseudocyst.
Right. If you see here, this is the stomach. This is the transverse colon. There is gas here. Look at this bubbly type of an appearance. With this history, what else can it be? On a CT, what do you think?
Oh, so it looks like Pneumotosis.
No, where is it? Anatomy wise, if you see, this is the stomach. Behind it, this is what we call the lesser sac.
Oh, yeah.
Right? Of course, if you had all the sequences, you would have picked it up. So this is a what? Pancreatic abscess. Right? This bubbly appearance. This is a complication of acute pancreatitis, and this is a pancreatic abscess of the lesser sac. Okay, this patient is similar, but which organ are you worried about?
So I'm worried about the bladder.
Okay, anything else comes to your mind?
So, bladder, the other thing could be the rectum.
Anything else? Okay, so the patient came from a maternity ward to, she was discharged from a maternity ward a few days ago.
So,
yes.
So it'd be the uterus, and it could be an infection secondary to retained products of conception.
Absolutely. So what we call the puerperal sepsis. Of course, it's very difficult, but you have to stretch your imagination. What is happening? So this patient, of course, is status postpartum. So the uterus is still large, and with that, there is gas here. So he's very sick. Thank you. So next is candidate number 8. If you can raise your hand, please. Can you hear us, please?
Yeah.
Okay. Very easy film, spot diagnosis.
So on this frontal chest radiograph of a skeleton mature patient, there's a large gas hollow viscous, which is occupying the right upper quadrant, starting from the right iliac fossa. It hasn't got any hostra within it. I can see some hostra, although on the left lateral side. So my diagnosis for this is likely to be Volvulus, and I can't see any Pneumoperitoneum. And
excellent, excellent, well done. Conclusion.
So as this patient has got a volvulus, so I would relay the findings to the clinical team, and then.
Which kind of volvulus? I'm trying to hear which part of bowel you are talking about. Volvulus
sigmoid volvulus.
Excellent. Okay, well done. I'll take over. So well done. So this is what we call the coffee bean sign. a coffee bean sign where you can see that this, volvulus of the sigmoid, actually this is an old film, but it gives you the concept in a much better way. What happens in sigmoid volvulus, that there is an inverted U appearance, and this coffee bean sign might not be visible in each and every case, so you have to see the concept. Ahostral margin. So this is the limb which is going superiorly, and this is the limb which is coming inferiorly. In between these two limbs is this white line, which is because of the opposing walls. And there are signs in old radiology literature, inverted U sign, ahostral margin, the apex under the left hemidiaphragm, apex superior to the level of T10, things like that. But this concept is, if you see, there is a sign in radiology, we call it inferior convergence. And I want you to remember it. If you stretch your imagination, this is the outer line, line 1. Number 2 is the line of opposing walls, number 2. And there is the third line, which is the line of this loop, which is descending down. Inferior convergence is that these 3 lines will converge to the point to the left side of the pelvis. This sign is known as inferior convergence. What I take home point is that the coffee bean sign looks very, a good word to use. But having said that, all cases will not be classical. This inferior convergence is a very nice sign to remember. So this was sigmoid volvulus and a barium examination of the same. There was no need, by the way. Okay, is this a sigmoid volvulus? What do you think? Or not? If not, then what else can it be?
So on again on this frontal abdominal radiograph, there is a dilated bowel loop, and I can see some hostra, incomplete hostra within it. It is on the left upper quadrant, and I can see gas within the small bowel. So if because of the location, I'm thinking that this could be cecal, but in cecal volvulus, it's the small bowel that is more dilated. So again, I think that this is a sigmoid volvulus.
Why have you changed your opinion from cecal to sigmoid just on the basis of small bowel? Okay.
Yeah, because I thought that in cecal volvulus, because if it's a twist in the cecum, then it should be the proximal, which is the small bowel, which should be dilated.
One of the principles of large bowel obstruction, you remember, large bowel obstruction can be with ileocecal valve, which is, not patent or patent. So small bowel is a tricky finding. You should never, ever, make this opinion that I will look at the small bowel and then I will conclude. Your basic principles are the same. You have picked up that this thing has got hostral. Now, if you hostral, so this is not sigmoid. And please remember the basic concept. The patients who have got mesentery, the cecal mesentery, which is redundant mesentery, that will twist. So sometimes the cecal volvulus will sit in the left upper quadrant like this. That's a take home. But main point for you to remember is this hostral margin. On a contrast examination, what happens is that contrast comes here, and if you look carefully, this loop, there is no contrast. So there is a twist here, and again, you can see hostra. So this was a cecal volvulus. Okay, what do you think is happening here?
So there is a pneumatosis intestinalis, because I can see air within the bowel wall. That's it. That's projected. No. It's the gallbladder. It's the right upper quadrant. So it's there within the gallbladder. Yeah.
So this is a emphysematous cholecystitis. What do you think is happening here?
So on this one, again, I can see some thumb printing because there is edematous bowel wall, and I can see that loop in the left iliac fossa, and I can see some dilated bowel loops that are in the pelvic region as well.
Okay.
And
Is here.
and again there is some air, yes, and then there is a triangular air in the region of the gallbladder.
Okay, so this is a bit of pneumobilia.
Is it Morris? Yeah.
So what's happening here?
Oh, so and there is a radiopaque density as well in
So
the left
when
iliac fossa, and yeah, so this is a gallstone ileus because it has got all three signs, which are small bowel loop dilatation, and then it's a calculus, and there is a pneumobilia as well. So it's a small bowel obstruction secondary to gallstone.
Excellent. This is an erect film, which just to develop the same thing, you see this string of bead sign, string of pearl sign, dilated loops, and this is inside gallstone ileus. So we finish this, and thank you very much, candidate 8, and we are going to candidate 9. I will crack on for next 5-7 minutes, and then we will give you a break. So okay, is it projected? No. Sorry, I think I have not shared it correctly. So let me try it again. Screen share. Is it projected now?
No, yes.
Candidate 8, sorry, candidate 9 now. Can you raise your hand? Yeah, candidate 9 is with us, and over to you. Now, this case, I want all of you to concentrate. This is a very good teaching case, learning case. I want you to concentrate. And after this, I'll give you a 5-minute break, and I'll go into a bit of a teaching mode on this case also. So over to you, candidate 9.
So this is a, can you hear me?
Let me give you a hint that this is a story case. It tells you a story, and you will tell me what is the story. Over to you.
So this is a lateral projection of a variable contrast follow. There's contrast outlining the hypopharynx and proximal esophagus, with some contrast seen with some contrast with some evidence of aspiration. There's impression of filling defect at the level of C2.
Don't worry about filling defect. So you have picked up some aspiration. What do you think is happening? Let me ask you, why has this examination been done? And this is, have you picked up the story?
Is this to check someone's swallow post-stroke?
Post what?
Stroke or...
Oh. Then why has this happened?
They haven't got a safe swallow and they've aspirated?
No, but this aspiration is not going anywhere into, let's say, the tracheobronchial tree. Actually, I have not shown you the AP. It is going out. It is going into the skin, actually. Do you see anything, any story written here on this? It's a post-surgical case. What kind of surgery has been done? No. Okay, fine, don't worry. The point is that it's a difficult case, but the but is it has come in the exam quite a few times. Oh. Sorry, I think you got muted. Were you saying anything, candidate 9?
Yeah, sorry, I was, yeah, I got muted. I was saying, is this, has it been some sort of esophagectomy or?
Excellent. So good thinking, and I will take over, right? All of you, if you can concentrate on this, because this is a very good teaching case. Part of it I will teach you in head and neck module, but let me tell you that this has happened so many times. This is a normal barium examination. Even last attempt, one of my students, the examiner asked all kind of anatomy on these views. What is this? What is this? What is this? Now, this is a post-total laryngectomy case. The case is actually post-total laryngectomy. So let me tell you the normal anatomy. Normal anatomy, this is an AP film of barium, and this is known as a veliculi here, and this one is right and left. This is the piriform sinus and the piriform sinus. On the lateral film, this is the veliculi, this is the hyoid bone, and this is the piriform sinus. The tongue impression is here, and the epiglottis is here. This is post-total laryngectomy. Complete anatomy is distorted, and you have to pick this up. You have to tell the examiner what has happened. Look at the hyoid bone, and the hyoid bone is missing. And look at this, it has become a featureless type of a inverted V smooth outline. We will come back to this when I go back to the basics. So let's go back and try to cover the anatomy. Now, we are interested in the anatomy of the pharynx. Please remember that if you draw a line through the hard palate here, and maybe the soft palate here, superior to that is the nasopharynx. We are not interested. Another line which you draw here through the superior border of the epiglottis, this is the oropharynx. Now, anything which is below that is known as the hypopharynx, also known as the laryngopharynx. In radiology, usually we use the word hypopharynx. Anatomists commonly use the word laryngopharynx. It's the same thing. Now, the hypopharynx is where the piriform sinuses are, and it is in continuity with the esophagus at the C6 level. And this is the cricoid cartilage. And this is the epiglottis. Take home point on this picture, this diagram, is midline hyoid bone. If you see the epiglottis, there is a fold of mucosa which is going from here to the tongue, and we call it glossoepiglottic fold. And within that is what we call the hyoepiglottic ligament. So there is a connection between the midline tongue and the hyoid bone and the epiglottis, and that actually forms this midline indentation here. This is that glossoepiglottic and the hyoepiglottic ligament together, right veliculi, left veliculi. So this is a very important point to remember. Now, on a plain film, if this is the hard palate, then superior to that is the nasopharynx. This is the hyoid bone, and this is the oropharynx, and inferior to that, this will be the hypopharynx. Cricoid cartilage is here. So on an MR, you can see the same thing, and just epiglottis. So this is the oropharynx, and this is the midline hyoid bone. This is the hypopharynx, and from C6 onwards, the esophagus is visible. Same thing on a CT scan. Oropharynx, and this thing is the laryngopharynx or the the hypopharynx, and the hyoid bone in the middle. Look at this picture. Epiglottis, And this is that glossoepiglottic fold, and this is pre-epiglottic fold. And on an axial diagram, same thing here, epiglottis, and this is the glossoepiglottic. This space here is the valliculi, this is the valliculi. This is the piriform sinus, this is the piriform sinus. Take home point, valliculi are anteriorly placed, piriform sinus is posteriorly placed, and piriform sinus ultimately is in continuity with the esophagus. And this is how it projects on a lateral, and this is how it projects on an AP film. Anatomy of the larynx I will teach you in the head and neck module. So look at this picture now. And now you can understand it's a featureless. Where is the valliculi? There is no valliculi. Where are the piriform sinus? There is nothing there. And where is the hyoid bone? It's missing. Take home point is that this is a status post total laryngectomy. We will learn this in the head and neck module. But when there is, invasion of, let's say, the cricoid cartilage, they have to do a total laryngectomy. There is a concept of partial and there is a concept of total laryngectomy. So then you will get this featureless type of upper esophagus. And you have to tell the examiner that this is what has happened. Now, why do they ask this in your exam? Because these patients usually are old age patients and they will also have radiotherapy. Because of post-radiotherapy, it's very common for them to develop fistulas. And these are cutaneous fistulas, and that is why they will end up with you for contrast studies. This was a gastrographin, by the way. But similarly, you can do a barium also. And this is cutaneous. The fistula is visible. They just want to see the outline and tract. So this is why this becomes a story film. Historically, now I'm going into a slightly different world. This is esophageal carcinoma. And historically, people have even pulled up small intestine. This is a historic film. I don't think so anybody does it now because they will always, part of the stomach might still be there. But they have pulled up whole of the small bowel. But with that background, look at this. And this you have to remember for your exam. That the patient has got, some sort of esophagectomy has been done. And then a portion of the stomach, this is the new stomach. And radiologically speaking, there can be films in the exams which can come and have come. So I don't have any such example with me, but this is a very good example from StatDX. And I just wanted to show you, because in the exam tip, beware of post-surgical appearance. So I have shown you, total laryngectomy appearance. Beware of this, this esophagectomy. And similarly, in the stomach module, I will show you Billroth 1, Billroth 2, etc., which have come in the exam. They might show you a plain film like this, in which you will say, oh, there's a mediastinal mass and things like that. And there might be some stigmata or some evidence to show that this is post-esophagectomy. And you will be stretching your imagination, what can it be? And actually, it's simple, post-surgical. So this is exam tip to remember. Remember post-surgical appearances. This is a CT. Okay, we stop here, 5 minutes break, and when we come back, then we will continue. Over to you. Number 9, please.
This is a contrast swallow. I can see the cervical spine, so I'm assuming it's the hypopharynx. It's a condon view. So there appears to be a caliber change within the hypopharynx. It's got quite a well-defined shape with smooth edge. I'm wondering whether there's there raises possibility of a stricture in the proximal esophagus.
Okay, hint. If you see here, there is proximally, there is a bit of dilatation. Do you see this thing here, and do you see this thing here? And there is a sign here which is related to the aircraft industry. Hint from my side. Have you ever read about it?
I'm not sure, sorry.
Okay, so this is a classical case, and I'm sure you might not have seen it in your clinical practice, but please remember that this is an exam case. And this is a case of a web, esophageal web. And this is known as a jet phenomena. I'll come back to you. Jet as in, aircraft jet. Now, this is a viva question, by the way. What are the associations of the web? And you make a note of this. Now, basically what happens is that this is a condition in which there is, proliferation of the mucosa, and it just projects inside into the lumen, and there can be various shapes. So it can be, anterior, it can be lateral, it can be posterior. And this is what I am showing you. This is circumferential. The histological concept is that this mucosa, all layers are not involved. So the muscularis is not inside. And when there is circumferential web, then this is what can happen. And this becomes an exam case. And basically there is a bit of upstream dilatation or hold up, and then contrast goes through a small area, and that is why we call it jet phenomenon. And these are two different examples. So this is an aunt mini case. Either you know it or you don't know it. You can see anteriorly there is a shelf-like filling defect. Remember these words: shelf-like filling defect. This is slightly, more advanced or a more prominent example of the same. Yes, please. This is your last case, candidate 9 and candidate 10. Please be ready after this. Over to candidate 9.
So this is a contrast swallow, the condon view of the hypopharynx. There's contrast outlining the vallecula and the piriform sinuses, and then there's this well circumscribed outpouching with a air fluid level in keeping with the pharyngeal pouch. I would have assessed a lateral projection to see whether it was.
So confirm?
Yeah, Zenker is divertical.
Okay, I'll take over. Well done. So you can mute yourself, and candidate 10, be ready. So now pouches in the this is from your book. Have I unmuted you, candidate 10? Yes?
No.
No. Okay. Can you raise your hand again, please, candidate 10? I cannot see you. What is happening?
They're at the top of the participant list.
Yes, now I can see you.
Hi,
You are with us?
yeah.
Okay. The case I'm just teaching on this case, so I'll ask you the next case. Now, This is 7.3 in your book, pharyngeal and esophageal pouches. And Zenker's diverticulum is a diverticulum, which is what we saw in the previous case. Other than that, please also remember that a traction diverticulum has also come in the exam. Zenker's is favorite. In Zenker's diverticulum, what happens is that there is a point of weakness in between the inferior constrictor and the cricopharyngeus, and it projects laterally or posteriorly. But in the exam, they will show you unusual presentation of a Zenker's diverticulum. An unusual presentation, you have to, this is the exam tip, beware. Unusual presentation on a plain film, a foreign body which is lodged in the Zenker's diverticulum, that has come in the exam, or a nasogastric tube which has gone inside and coiled up inside. So if you see this CT from the literature, you will be scratching, oh my God, what's happening? Is there an abscess there, and things like that. So stretch of imagination. So beware of Zenker's. This is a case from STAT DX where there is a large Zenker's which is sitting in the superior mediastinum, and on a barium it looks like this. So beware of plain film, particularly. They have shown many a times in which there is, they might show you a lateral. If you see this, they might show you a lateral plain film where there will be bubbles and things like that. Here you will be worried, oh, there is an abscess, and they will say the patient is fine, and that is Zenker's. Number two, same film but with a foreign body sitting inside, a plain film. So beware of Zenker's. Traction diverticulum, again, etiology is different. Traction means that there might be lymph nodes which will pull the part of the esophagus towards it, and it gives you a classical appearance. Usually there might be, so beware of traction diverticulum for the exam. Epiphrenic diverticulum can also be because of what we call pulsion diverticulum because of motility disorders. So this is the list in your exam, but I just wanted to show you the exam cases which have come or can come. Okay, Aunt Minnie case for what we call pattern recognition. Just give me the pattern. How will you describe this film? Over to you, please.
Sure. This contrastal study of the esophagus, we are at the level of the lower esophagus. We have got some linear opacifications at the distal esophagus near the gastroesophageal junction.
So look at this mucosa. Normal or abnormal?
Abnormal.
And how, I'm trying to hear the words. How will you describe it?
So linear lucency. There's no pseudo. I'm thinking of pseudo diverticular, but at the side wall, I do not see any abnormal outpouching.
Very good. So this pattern, classical description will be that it gives you a coarse or a fine granular pattern. Remember those words. You see, usually the esophagus is quite, it is a very smooth, and then you see these coarse granular pattern. And this is a differential diagnosis where it is a huge list of, inflammatory, infective, etc. Because of time factor, I'm just skipping points, but I want you to develop your eyes on this. And once you pick it up, then the examiner is going to ask you differential. And then this is the differential. So the idea was just to develop your eyes on this finding. Okay, spot number 10. What is this?
Nutcracker esophagus.
Nutcracker or corkscrew.
Corkscrew.
Right. So corkscrew is tertiary contractions, and this is a motility disorder. It's an Aunt Minnie, nothing else. it should be confused, tertiary contractions of the esophagus. And here is a mix-up of two things which I just showed you. This patient has got a motility disorder, so tertiary contraction, and with that pulsion diverticulum. So pulsion diverticulum are associated with motility disorders. Yes, please describe this stricture.
So there is a focus stricture in the mid esophagus with smooth margin, and there is distally we have resumption of normal caliber esophagus.
Pertinent negatives. Your description was very good, but I want you to add your pertinent negatives.
So there is lack of shadowing, shouldering.
Excellent, well done. So when you describe a stricture in the bowel, these words should be pertinent, negative, or positive. When you are describing it as you have described that this is a smooth stricture and normal mucosa, there is no shouldering, should be your pertinent negatives, no mucosal destruction. So now, can I ask you this appearance? Is it for a benign stricture or a malignant stricture?
Benign.
Irony is that esophagus, remember it like this, does not follow this principle. And look at the differential diagnosis here. Esophageal strictures smooth. And you are absolutely right that there are many things in the smooth world which can cause, smooth strictures. But irony is that malignant lesions can also cause smooth. So we are not very good. I remember it like this, that if you find a frank malignant stricture in the esophagus, like mucosal destruction, shouldering, etc., you are very confident that this is malignant. When you find a smooth stricture, you should still keep what we call malignancy in the differential. And I have seen quite a few, and particularly which are coming from outsides, something sitting in the mediastinum, small cell carcinoma and things like that, and secondary invasion of the esophagus. Having said that, classically in the exam, they will show you cases in which, there will be benign etiology. One thing which I want you to remember is scleroderma. Now, scleroderma is an extremely important exam case. It can come as a long case. It can come in so many different, films. Scleroderma involves whole of the bowel, so they can show you, esophagus or a small bowel or large bowel. I'll show you later on. Point to remember is that esophagus is the most common site of involvement of scleroderma. Remember that. And irony is the films which come in the exam are mostly of large bowel or small bowel, because the findings there are more specific there. Now, another thing which I want you to concentrate from this book is, because this will save you something in the exam, neoplastic, submucosal, and extrinsic masses. What does it tell you? Extrinsic masses is the type of mass which I was telling you, mediastinal tumors. So even malignant tumors can cause smooth stricture. But I want you to concentrate on something else. These words you have to remember, but these will be key for your differential diagnosis. And the classical case, how will you describe it, candidate 10?
So there's an area of indentations in the, presumably this is a lateral projection that would be posterior wall of the esophagus. If it's AP view, this will be a lateral wall. So, so just concentrate on your description. So what is happening? So So, and the indentations is implying there is an extrinsic compressions on the esophagus.
Okay, debate.
So we,
excuse me, debate. The debate is, you have said extrinsic impression. I will take it. I will not disregard it. But the debate is, can it be sitting within the wall and projecting into the lumen? What about this idea?
because the contrast is still coating the esophageal wall.
So the hypothesis is that something is sitting within the wall, and then it is, you know, projecting into the lumen and giving you this kind of appearance. What about, do you see this idea?
Okay.
So you see, this thing is, you are absolutely right. When you are looking through the lumen, you cannot make out if it is coming from outside or is it within the wall. And I will teach you how to discriminate between the two when we will cover barium in the stomach, and particularly large bowel, which is important in the exam. Having said that, we are not very good in contrast studies. Is it intramural versus extramural, means extraneous? So now, debate point is, how, as an examiner, I am going to ask you the differential diagnosis. Okay, I take your point, it might be sitting outside. Now, if it is sitting outside, means it is coming from the mediastinum. Do you see anything there, any soft tissue there?
No.
No. So, you know, there is nothing big sitting. So it must be in the wall. Now give me the differential diagnosis of this.
So we have, so given the smooth margin, and we can see there's no erosions of the mucosal wall. So I'm going more of the benign etiology, like a leiomyoma.
Excellent. Excellent. Now I will take over because of time factor. Well done. So if you see here, this differential will save the day for you. Read it carefully. 7.6. One of the subheadings is that this is the whole, you know, inflammatory, neoplastic, submucosal, and submucosal. So I was going into this territory. Submucosal lesions and extrinsic masses. So submucosal lesions, leiomyoma. And your book tells you that this is the most common due to smooth eccentric submucosal mass. Calcification is highly suggestive, and it can be multiple also. Now, rare lesions, there are many words here, rare reasons, which can be a lipoma, it can be nerve sheath tumor, hemangioma, glomus tumor, solitary fibrous tumor, etc., etc. Read that. GIST is extremely important. Now, GIST is a favorite tumor for the exam. I will show you in the stomach, etc., where it is, you know, more specific. But remember this. Esophagus is the least common location of GIST. So GIST can happen anywhere in the GIT, right? But it is least common in the esophagus and much less common than the leiomyoma. And so this is an important point to remember, though it can happen. GIST can also happen outside the GIT, you know, in the mesentery and things like that. Many organs have been reported in literature. We'll come back to GIST later on. Next time. Okay, thank you. One more film for candidate 10, and then candidate 11, be ready, please. This is your last film, candidate 10. Over to you. This is an Aunt Minnie case. Just give me the diagnosis.
Esophageal varices.
Excellent. So this is varices of the esophagus. You get this serpentinous filling defects, and this is how it looks like. And when, remember one thing, that cirrhosis will cause varices which are going from down to up, and when there is superior vena cava obstruction, as in mediastinal tumors, etc., there can be varices which can come from up to down. So these are esophageal varices, and looks like snake anaconda sitting inside the lumen here. And this is another example. Candidate 11, are you with us? If you are, please raise your hand. So I have unmuted you. And candidate 1, be ready for next, maybe I'll give you a one-odd film before we finish. So candidate 11, over to you. Sorry, I have not unmuted you. Just bear with me.
Hi. Yes.
Hello, candidate 11. Can you please tackle this? Chest X-ray.
Yes.
I'm not worried about here. Look at the mediastinum. What's happening in the mediastinum?
Okay. So this is the frontal chest X-ray of a skeletally mature patient. What I can see is there seems to be an elongated soft tissue mass starting from the right superior mediastinum along the right paracardic border. It also appears to be involving the left side of the mediastinum and along the hard border. So this seems to be a dilated viscus in the mediastinum. My prime differential would be that this is a dilated esophagus, probably eclasia.
Excellent, well done. So what are you going to do next?
I would like to do a contrast swallow.
Okay, well done. If you see this film, what is happening, and this is, eclasia is a very important film in the exam, favorite, and they will always show you on a chest X-ray subtle signs. And you have to look this linear shadow here, which causes a double sort of a shadow of the mediastinum, boundary of the mediastinum. If you look carefully, there is a bit of dilatation here. Of course, right now we are doing esophagus, and you are so confident about it being a eclasia, but in the real world, always keep it in your mind. So well done. Now, the correct answer is yes, you will do a solo, and these are various examples where you can see, this is not the same case, this is a different case. You can see this rat tail appearance, a rat tail appearance here, and then dilatation, eclasia, cardia. Okay, sudden chest pain after bout of coughing. What is your finding?
Okay, so this is frontal chest X-ray of a skeletally mature patient with history of sudden chest pain after bout of coughing. I can see that there is a subcutaneous emphysema on either side of the neck. I can see that there is a subtle lucency outlining the aortic knuckle as well
Excellent.
as the...
So conclusion, well done. So what is the conclusion?
This is pneumomediastinum secondary to oesophageal tear or Burhaft syndrome.
So what will you do?
I will do a CT or a contrast solo. CT with contrast, sorry.
CT is fine, good answer. And sometimes what happens is that we have to do a solo examination. What happens on a CT that at times anatomy is not known. You know, history is, this is a horrendous condition. I've seen quite a few. Where I work is a cardiothoracic center. We work in a cardiothoracic center, so I've seen quite a few of them, and particularly on call. And this is a horrendous condition where a patient is absolutely fine and then has a bout of coughing and with this tear. So clinical history is very suggestive. CT is the correct answer. In the real world also you do a CT scan. But many a times the surgeons, they want a bit of anatomy, you know, where is the, can you please outline where the tear is, upper or middle or whatever. So the point is, a viva question is, which I'll ask you, number 11, what kind of contrast will you use?
I would use a low osmolality contrast medium.
Excellent. So that's the correct answer. Well done. Where is this foreign body?
This is in the esophagus because I can see the round projection in the AP film.
Right. Take home point that X-ray, on a chest X-ray, a coin or a flat object orients in a coronal plane if it is in the esophagus. So that is pathognomic of a foreign body in the esophagus. Yes, please. Over to you. Can you describe this?
Right. These are spot films from contrast swallow in a 70-year-old patient with dysphagia. What I can see is there is a long segment of narrowing of the esophagus with mucosal irregularity. There is shouldering, and which makes it very worrisome for aggressive lesion, a malignancy.
What are you going to? Well done. I'm stopping you because of time factor. What will you do next?
CT scan.
How will a CT scan help you?
It will outline the oesophageal lesion better. Otherwise, we can. Sorry.
Then what will happen?
It will go for endoscopy.
Here you are. You see, the correct answer is an endoscopy. Please remember, remember, remember. And this is something which I have observed many a times in the 2B exam. Classical question, what will you do next? And people jump to next imaging modality, particularly in GIT. You have to have a tissue, and in the real world also, this is exactly the scheme of things. When you have picked up that there is a tumor on let's say, this thing, you have to ask for, first of all, an endoscopy and a biopsy. Once the endoscopy is, the biopsy comes, and you can ask for in tandem also. But having said that, the first idea here was that the strictures or irregular strictures, interestingly, in the esophagus, as I have told you, that benign strictures can have malignant causes. Irregular strictures can also have benign causes. So remember that esophagus is slightly tricky in this way. Now, suppose biopsy came out as a malignancy, it was an esophageal carcinoma. So number 11, question to you. How will you stage this?
It can be staged by endoscopic ultrasound for the T staging and CT chest to look for distant metastases.
Okay, very good, well done. Now, if you see here, number 11,
yes.
Okay, I'll give you, okay, please keep continue with us. I'll go into a bit of a teaching mode here.
Sure.
Now, these are key questions. A few of the tumors in GIT I am going to teach you, and many of them I am not going to teach you. Esophageal carcinoma is one of them which you should have some concept for the 2B exam. Beyond 2B is a different world. I always divide it like this. So for 2B, I will teach you carcinoma esophagus up to extent. Now, first of all, key exam questions is that how are you going to stage it? Your answer was absolutely perfect. That for local staging, you will do a CT scan, and for a T, you go back to the basic T and M staging. So the best modality for T staging is an endoscopic ultrasound. Sometimes you cannot do it because, the lumen is very tight, etc. That's a different word. Otherwise, you do a CT chest, abdomen, and pelvis, and you do an endoscopic ultrasound. With that, we also do a PET scan. Now, why a PET? In UK, we don't use PET scan the way people in USA use it. They do it for each and everything. There are a bit financial reasons also involved. But in esophageal carcinoma, the lymph nodes are extremely important, and this is an exam type of a concept. Please remember, in a lung carcinoma also, lymph nodes are so important that if a lymph node crosses to the mediastinum, in the mediastinum to the contralateral side, it completely changes the staging and prognosis in a lung carcinoma. So PET scan is absolutely critical. Similarly, in an esophageal carcinoma, there is a concept of local nodes versus non-local or distant nodes. The concept is that local nodes are, end stage, but if they are not local, then we call them metastasis. That is the concept. Let me give you an example. For example, there is a tumor sitting at the gastroesophageal junction, and there are gastric lymph nodes. These will be known as local nodes. On the other hand, there are nodes sitting at the level of arch of aorta. These are non-local. These are metastasis. Similarly, if there are nodes sitting in the retroperitoneum, becomes metastasis. So for that, PET scan is done as a routine. So the answer is for TNM, T staging CT, and M also CT, and endoscopic ultrasound for T staging, PET for particularly for lymph nodes. Now these are the rates, and at times you do a new adjuvant chemotherapy. Nobody is going to ask you. This is just for your knowledge. And combined CT and ultrasound, EUS has got quite a good 86% accuracy.
Close approximation in the subcarinal region. The right and left main bronchus seems to be spared, so I think this is operable.
Okay, thank you very much. You can mute yourself. Well done. But this particular case, audience, I will come back to this case, right? So we will debate this case. Now, let me take over. And you see, in esophageal carcinoma, please remember there is no serosa. So, T staging, PET for particularly for lymph nodes. Now, these are the rates, and at times you do a new adjuvant chemotherapy. Nobody is going to ask you. This is just for your knowledge. And combined CT and ultrasound, EUS has got quite a good 86% accuracy. Now, number 11, this is your last case. Number 1, be ready for you're going to take over. So, this is a case of esophageal carcinoma. Biopsy has been done. You have done a CT scan. Tumor is sitting here. Tumor is sitting here. Is it operable or not on CT criteria?
Okay, this is spot images from contrast enhanced CT. I can see the esophageal lesion. It is in contact with the aorta, but the contact degree is less than 90. However, I do see that it is in close approximation in the subcarinal region. The right and left main bronchus seems to be spared, so I think this is operable.
Okay, thank you very much. You can mute yourself. Well done. But this particular case, audience, I will come back to this case, right? So we will debate this case. Now, let me take over. And you see, in esophageal carcinoma, please remember there is no serosa. So tumor can go right and left into various organs, because serosa in a way confines a tumor in rest of the GIT, but here there is no serosa, there is adventitia. And this concept is what I was, non-regional nodes is considered metastasis. Now, with that background, see here, I just want you to concentrate on T4 tumor. This is T and M staging. T4 stage, T4A, T4B. Some of them are still resectable and some of them become unresectable. Now, if it goes into the pleura, into the pericardium or into the diaphragm, it is still resectable because you can remove that part of the pleura or pericardium or diaphragm as well as the tumor. Unresectable tumor that invades other adjacent structures such as aorta, vertebral body, trachea, etc. So, regional nodes, of course, N staging, I am not going to go into details, but N staging 1 to 2 is N1 and N3 is 3 to 6, more than 7 is N3. Now, here is the take-home point, and you have to concentrate on what I am going to teach on this particular slide. As we considered previously, that EUS is the top modality to pick up T staging, but there are some CT criteria to convert it into a T4B tumor. And this T4B on a CT criteria becomes inoperable. So there will be cases on which you on a CT can also suggest that this is a inoperable case. In some of these cases where the findings are debatable or subtle, we will still like to do an EUS. But in the real world, what happens when there is a tight stricture, they cannot do EUS because it cannot go through the lesion. Having said that, what are the main things you are looking for? The main things you are looking for is in a very large tumor, signs of tracheal invasion. So if there is posterior indentation or anterior displacement of trachea, you can raise that on a CT criteria, I'm worried. Please remember that our sensitivity specificity is not as good as EUS. But these are the CT criteria, right? Second thing is left main bronchus. This is a very big tumor, so it is also averting the right main bronchus. But usually it is left main bronchus. Anatomy-wise, esophagus is sitting posterior to the left main bronchus. If there is displacement of the left main bronchus anteriorly, you call it that I am worried. Number two, if there is narrowing, you call it with more confidence. And I've seen cases where you can actually see breaching it into the left main bronchus. So anterior displacement or narrowing, call it. So this is, left main bronchus. Aorta, if you see this aorta, I will show you in the next slide. So this is the main take-home point. As an examiner, if I want to show you esophageal CT for your concept of staging, I will show you aortic invasion, and I will come back to this. But pericardium, look at this tumor. This tumor is at the level of left atrium, and it is causing indentation here. When you see indentation, you call it that there is, I'm worried about pericardial invasion. Now, concentrate on this. This is for me the most important concept of invasion of the aorta. Basically, the descending aorta is here. Look at these rules. If less than 45 degree, now if you this is the aorta, this is the tumor. If the contact between the tumor and the aorta is less than 45 degree, means it is touching but less than, you divide it. This is one line, this is another line. From here to here is 45, from here to here is 90. 45 is this one, this is 90, and this is 180. So 45 to 90 degree is doubtful, and more than 90 degree is definite. So in this particular case, you can see that it is about 180 degree. Another sign which is given in literature is that if you see soft tissue of the tumor in between the aorta and the spine, again you call it. So this case is aortic involvement. When we will learn pancreatic carcinoma, I will teach you when we reach that point, but please remember the discriminator. There the sign is 180 degree. Less than 180 degree. So for example, this is the vessel, this is the tumor. This tumor is abutting the vessel less than 180 degree. This is the vessel, this is the tumor, what less than 180 degree, we will still call it operable. It is not invading the vessel. Here, when it is more than 180 degree, we call it, this one is 360 degree actually. So the difference between esophageal and pancreatic carcinoma concepts. And this is the case which we had done. You will agree that in this case, you know, there is a tongue of tissue which has gone in between the aorta and the vertebra. This is one sign, but the abutment is also definitely more than 90 degree, maybe close to 180. So we will call it a T4B tumor. Okay, candidate, last few films are left. Candidate 1, are you with us? I think 2 films are left, if I'm not wrong. Staging, what do you think?
Okay,
Just
so
concentrate on these 3 slides. Esophageal carcinoma staging.
So there is contact with the descending thoracic aorta of about 45 degrees. It's also inseparable from the left atrium.
What is your conclusion?
So T4?
T4, excellent. So if you see here, now this is the, if you divide it here, this will be 90, so maybe it is 90. And even if the patient is a young, here if you look carefully, there is a bit of fat plane in between. So you are not going to call it. Here it becomes, you know, in that territory. In a young patient, what we do is we must do a, so, you know, EUS also. We are wrong many a times. But what we are learning is that this is the CT criteria with a small print disclaimer that we are not perfect on CT, but we have to call it on CT criteria. Now, this indentation here means pericardial invasion, but as I told you, it will be a T4A tumor. Here is T4B tumor. This is operable, this is inoperable. I think last case of the day, yes. So you've got the last case of the day, number 1. Over to you.
So there are multiple intramural diverticulosis.
Yeah.
So pseudodiverticulosis of the esophagus.
Okay, so this is a Aunt Minnie case. An Aunt Minnie case is that if you have seen it once, you will pick it up. You can mute yourself. Actually, this is the last case, and after this, we will end the session. So if you see it once, you will never miss it. Otherwise, you will be absolutely, you know, searching for answers. This is a benign condition where what is happening, pathologically speaking, there is deep mucous glands, the excretory glands of deep, you know, the mucosa. The ducts of them, they get dilated. And these ducts are in communication with the lumen. So when the patient drinks barium, that goes into those dilated ducts. And or when you see them in a profile, they project like this, and on they project like this. And this is what we call intramural. So intramural pseudodiverticulosis. It's not going outside the wall. Interestingly, please remember that barium is more sensitive than endoscopy. Interesting. Because when they do endoscopy, many a times these openings might not be visible to them. So we are much better. With intramural pseudodiverticulosis, you will find strictures. Usually these are benign, and at times they can be malignant also. And this condition is also associated with many other types of diseases. So this is intramural pseudodiverticulosis. Right. So as I told you last time, the feedbacks, the number of feedbacks, as I've told you, in what, we always say that there is no teaching without feedback. So if you are, my concept is that if you have attended a teaching session, you must give a feedback.